Welcome back everyone to the Dr. Barry Krakow Part 2 video. I'm not going to say much here except that Dr. Barry Krakow is a veteran in this space and he trained at the Stanford Sleep Medicine Fellowship Program with Dr. Christian Guilleminault. I'll leave links in the description box to his services and book, which I recommend. If you haven't seen Part 1, I suggest you go see that first, then follow it up with this Part 2 video. Alright, let's get on to the video.
Okay, so building off of what you said, this is shaky knowledge, but I remember reading a PES study and they were identifying PES signatures, so negative pressure catheter. And I believe what I read was that even if there isn't necessarily flow limitation in the flow rate or in the PTAF or there can still be respiratory effort.
Right, it's the same phenomenon. In other words, sustained flow limitation theoretically would show up with a PES as this additional effort the individual is using. And Dr. Guilleminault and the people that were working on that, back in the early 1990s even, were raising questions about these types of phenomena. And this is why we say that even though nasal cannula pressure transducer is a very good surrogate, and Dr. Colin Sullivan, the inventor of CPAP, did the study almost 15 years ago showing that the pressure transducer and the PES were pretty close and good enough for clinical use. This harkens back to this phenomena that we don't have the easiest way to diagnose everybody with sleep disordered breathing. And some people really do have these more subtle conditions. And unfortunately, they get pushed aside by many sleep centers who go, well, you don't meet the criteria, so we're done with you. Go do whatever you want to do. And that does happen much more than people would like to think.
Just to completely clarify the point though, am I right to say some patients, perhaps the entire night, they could have completely rounded tops, but the average respiratory effort to get those breaths is too high and disturbing and is causing sleep fragmentation? Is that fair and right to say?
I think that's possible, whether it be the entire night or whether they might have some periods of normal breathing. I don't really know, because the last time I worked with, PES would have been when I was at Stanford. We may have seen it a couple of times in the 1990s at the University of New Mexico. But what you're getting at is it enough of the night? In my opinion, what you're getting at is it enough of the night that the person is having a problem and it should be treated? And certainly, if you go back to what many people in the field of sleep medicine have been saying for years, not, I shouldn't say many, people who are more forward thinking about advances in the field and the way healthcare is both deteriorating and evolving at the same time. If you walk into a sleep center and you say you have a sleep problem, you could easily argue it would be, okay, we're going to write you for a PAP machine. In fact, no, we're not even going to write you for it. We're going to give you a PAP machine and you're going to use it at home for a month. They go, wait a second. What about all the testing? What about all this, that? No. You walked into a sleep center. There's something wrong with your sleep. Go take this PAP machine. We'll show you how to use it for a month, and come back and tell us whether or not you think you're sleeping better. You realize how many people are going to come back and say, I mean, assuming they can use the machine and assuming it's not CPAP, but it's bilevel, well over 70% are going to come back and say, oh, well, you spot on here. Like, I'm already sleeping better. Thank you very much. Now what do we do? And they go, well, we're thinking about putting you in the lab because we want to fine tune this, or we're going to adjust some pressures and whatever it happens to be. That model of care could be done right now, easily. The ability of a sleep doctor to determine if somebody has sleep disordered breathing with a couple of questions, a couple of discussion points, not to mention, how many people are coming to sleep centers because everything else has failed? If everything else has failed, then gee, I wonder what else is going on.
Yeah, so this is really common too. What do you have to say? You kind of already answered this, so I apologize in some respect for re-asking the question, let's say. But there's a lot of patients who have really low RDIs and the breathing looks kind of good and they're confused. They don't know. They're like, do I have sleep disorder breathing or do I not? How does that patient figure that out?
Well, some of them already know they have sleep disordered breathing, even despite that test. And how did they know that? Because they have done their reading and they figured out the symptom cluster for themselves matches. They wake up in the morning with headaches. They have developed high blood pressure. They're noticing changes in memory and concentration. They're noticing they're tired and sleepy during the day. In other words, the list goes on of all these things. And they go, gosh, I've been to the doctor about this and for that. Nobody says I've got diabetes. I don't have a thyroid problem. With the internet, people read stuff and they go, no, this isn't what I must have. And they go to the doctor, and the doctor does a test, and it's a poor test for whatever reasons. And then that person ends up with, oh, I guess I don't have it. But then they have, cognitive dissonance because they go, but no, I do have it. That person goes to the next sleep doctor. They keep working at it because they know they have to do something because they're convinced. And sometimes they contact me or other people who provide more enhanced education to give them that confidence. There's another group of people, though, that are not as diligent in their knowledge acquisition or they're not as curious. In that situation, that's when you work on conservative sleep disorder breathing treatments. You'll say, well, there's an easy way to figure this out. Usually, start using nasal strips, use nasal dilators. If you have congestion, treat allergic rhinitis, treat non-allergic rhinitis. Go down that pathway so you can confirm for yourself something got better. Because there's no other reason for it to get better. If you did these steps and you got better, you just confirmed you have a sleep breathing disorder, despite what that other test showed. So that's how we generally deal with those two types.
Understood. That makes sense. Okay. PLM is another confusing concept. It's my understanding that some patients, because of the sleep disorder breathing, are gonna have a periodic limb movement. And the question is, are they having a periodic limb movement because they have periodic limb movement disorder? Or are they having a periodic limb movement because there's underlying sleep disordered breathing that's causing their sympathetic nervous system to kind of jolt and have a response? What does a patient do about that? How do you figure out if it is PLMD or if it's just
Right.
sleep disorder breathing?
Right. So you have to keep in mind that you're talking about the condition restless leg syndrome, periodic limb movement disorder. Restless legs is why you're awake, leg jerks is why you're asleep. And the field has deteriorated a great deal in my understanding of what are the developing consensus guidelines, because there was always this big question about what are leg jerks. Way back when, talking about the 1990s, there was always a debate. Oh, leg jerks are real and they cause sleep fragmentation. Oh, no, leg jerks are not real. They're not really anything. Just ignore them. So that went on for a while. And then everybody started focusing on restless legs, which clearly you can talk about because you have it while you're awake. And so you get these medications for it. And way back when they said, well, the medication that you treated your restless legs with will now treat your leg jerks. So that was the paradigm that went along for quite a while. But now, more recently, people are getting more and more out of balance and declaring that leg jerks can't possibly mean anything else but breathing. So all leg jerks should go away with breathing treatment, which I think is kind of odd that people are thinking this, because if you speak to doctors who have really dived into this, and I was just speaking to one just a couple of weeks ago, they've had the same experience I've had, which is there are people where you aggressively treat the sleep disordered breathing. You've done everything possible you can. They still have leg jerks. And the patient is saying to you, no, this response isn't what you told me I was going to get. We say, well, every study is showing leg jerks. Now is the time to pull the trigger. We can start you on leg jerk medication. It turns out many people don't want to be on leg jerk medication. So when we've seen these patients, It's delay after delay after delay. And then a couple years later, they go, okay, I'll try the leg jerk medication. And in the large proportion of those cases, once they went on the leg jerk medication, they come back and they would say it again, no pun intended, you guys should kick myself that I didn't agree with you to try it earlier because that's it. Now that I'm on this medication, and then we would put them in the lab, and most of the time we would see a decrease in leg jerks in those patients. It's not the largest majority, but it's not inconsequential. It's not rare. There are people who have these leg jerks, and it's unfortunate that the field of sleep medicine is trying to make it sound almost like leg jerks aren't even a condition to consider anymore, which I strongly disagree with based on this clinical type of picture that we've seen. And you can call it personally tailored medicine, but whatever you want to call it, it's real for that patient. And that patient absolutely gained tremendous benefit from being aggressive about doing a medication, or now, as they know, doing more iron studies, getting iron infusions and so forth. And that's great too. But even that does not mean that's the whole picture. These medications to treat restless legs can be very effective in treating leg jerks in a lot of people who have what appears to be an independent leg movement condition.
Do we know what that's caused by? Is there a preventative medicine aspect here where we target pediatrics and try to avoid PLMD somehow?
Yeah, don't injure your back.
Really?
I think the leading risk factor for leg jerks through the years, I think it still is today. I'm not sure. I mean, maybe iron deficiency is the leading one now, but it used to be if you had a back injury, your chances of having leg jerks were astronomical. And if you made the mistake of getting too old, like they did a study in nursing homes,
The
and they
mistake.
found out that virtually everybody in the nursing home had restless legs or leg jerks. So I don't think there's people who are definitely trying to understand it from a neurologic aspect with limited results. I think they now have a device you can put on your leg that tries to sense that you're going to have a leg jerk, and then it sends a false signal that teaches you not to jerk your leg or something like that. Or I take it back. I'm probably getting it confused with it teaches you not to get a restless leg sensation. So all these kinds of things are going to be on the market, and some of them will hopefully lead, to better treatments. But the best treatment by far is not have somebody on CPAP, have them on bilevel and ASV, where you can do what? Actually normalize the flow limitation, the third breathing event, and then that individual is likely to see less leg jerks.
I want to emphasize too, that was actually one of my favorite parts of your book, and I have it penciled into my calendar to go back and read that part because it was a lot of information that I didn't know of at all, and will be helpful
Right.
for me moving forward with what I'm doing. The other thing, I'm pretty sure you came up with this. There's a REM consolidation, very simple algebraic equation, REM consolidation index, where it's minutes of REM divided by periods of REM. This is your
Right.
idea, right? And I think
Right. So
you
there's
identified that having that index be above 15 is a pretty good clinical threshold in determining whether someone's going to present with daytime symptoms, say.
right. So all of this that we're talking about is much more what's called clinical, anecdotal, large number of cases, but not the highest quality research. Um, and so our model was called Sleep Consolidation Index, and Germain has one called Sleep Fragmentation Index. In many senses, they're the same thing. What happened was once we learned this phenomena, you switch somebody from CPAP to bilevel, and all of a sudden they go into REM and stay in REM. We kept asking the question, why was the field of medicine adopting this idea that if you have lots of little REM periods all surrounding one 30-minute area, you call it one REM? Why did they do that? And that's exactly how everybody scores it to this day, as far as I know. And so you could have 20 little sections of REM, but if they're blocked off, you call that 4 blocks of REM. And we said, that doesn't really make sense because think about these patients we saw that would go into REM and it was well consolidated. Maybe there's something there. So we just took, the total amount of minutes of sleep they had of REM. And then in our scoring on our sleep studies, we changed the algorithm of our Sandman technology so that each one was its own discrete REM period. And so the REM consolidation index was automatically calculated in anybody's study. And what we saw over time was that in the titrations, when they go on the bilevel, ASV, and so forth, they'd almost always go above 10. But generally, they'd be going up to 15, 20, 25, or 30 in that first titration with an enormously consolidated REM rebound. And when they didn't, we said, I bet that person's going to wake up and tell us they didn't sleep that well. And since there weren't that many people like that, it's more like anecdotal research, but we did see people that didn't sleep as well when they didn't consolidate the REM. The beauty of this was that when they would come back for a retitration, which might be 6 months, 2 years, 5 years later, those people on bilevel, ASV, and so forth, because they needed a fine tuning or whatever else came up that made us do the retitration, we would see that they were still consolidating REM well, and or that we were adjusting pressures, and then they go back into consolidating REM. So we think that's going to be a big deal, and somebody is going to adopt that as a technique, because originally it was a technique. It just used to be called REM rebound. You get your first titration, you get a lot of REM, and you go, oh, okay, see, the PAP must be working. But I'm saying I want to see that consolidated REM 2 years later, 5 years later. That would tell me, yeah, this is truly the way this system is supposed to work. And when they print normal hypnograms of somebody who's allegedly a normal sleeper, what do they show? This super consolidated REM, 4 periods, 5 periods, 6 periods. And they're like 10 minutes, 15 minutes, 20 minutes, 25 minutes. So then why wouldn't you want that in somebody who's using PAP?
Another brilliant point which you raised, which was like, well, yeah, duh, is like you asked, well, why aren't we not just measuring for normal breathing? Like, what is all this like mental gymnastics and talking about all these other things? Like, why not just measure normal breathing and then take the pathological patient and say, well, how much normal breathing does this person have during the night? And that should be a pretty good
Right.
proxy to the quality of the therapy that they're receiving, right?
Right, right. So we did that in our study that was published in the Lancet eClinical Medicine, where we were comparing ASV to CPAP, because we asked that very question. And we said, let's come up with a metric. And I actually don't have the metric in my mind because one of my sleep techs was the one who went on to become a PhD biomedical doctor. And she was the one who created that metric. It had about 10 variables in it, I believe. And we were just talking recently, and I've got to get that metric in front of me again. But we created that metric to show how the people on ASV had so much more normal periods of breathing than the people on CPAP. They had something like 80% of the night was perfectly normal breathing, or higher than that, could have been 85. And the CPAP was 60 or 65. I don't think the field of sleep medicine knows what normal breathing is. I don't think the field of sleep medicine knows what normal sleep is. I don't say that to be insulting. I say it to simply state that the way things evolve in a field depend on certain influences that can retard the progress. And clearly, the relationship between sleep centers, sleep labs, and making money by diagnosing people with sleep apnea and selling CPAPs has greatly retarded the field of sleep medicine, because now they keep saying, well, the insurance company said this and the insurance company said that. So many people have come along over the last 15 years saying, oh, here's a better way to look at breathing. Oh, here's a better way to look at breathing. But it doesn't change because all these people are tied into reimbursement. And well, Medicare says you've got to score your hypopneas this way. People will look back on it and laugh or be disgusted and say, why did they follow these tracks for so long? This clearly is not in the best interest of patient care. Certainly, they should be able to develop new models that are much more evidence based science-based, the AHI is clearly not a very reliable metric for lots of different reasons. It served its purpose in the beginning. It got us really moving to help build a field, but it's hurting so many patients right now. Even the patients who like walk in the door and say, well, your AHI is fine, so go away, or your AHI is low, so here, take this wake promoting agent or these stimulants because you need this. It's it's very problematic, and it's disappointing that the field has not found its self correction yet. And I don't know what's going to make that happen.
Okay, last few questions. This is a little bit of a separate note, but a really, really, really common question. Patients get put on CPAP. They go back to their DME supplier, whatever, the respiratory therapist, and they're like, look, I don't feel better. And the respiratory therapist or the supplier employee says, oh, well, it takes a while. You know, it takes a while for CPAP to start making you feel good. Is this a cop-out? Is there some truth to it? What does it mean?
Well, based on what I said earlier, the word cop out probably doesn't apply. What we're dealing with is a tremendous level of either ignorance and not spending time reading the scientific literature to understand, or not being properly exposed to a clinical care environment that helps you realize that that just couldn't be true. In other words, the number of people who get a great response to CPAP is only about 1 out of 3 as far as I've been able to determine. I'm talking about a great response. And a great response is what I get with ASV. A great response means you clearly notice your brain is working better because you slept better. Clearly, you have noticeable decline in fatigue, tiredness, sleepiness. Your blood pressure is under better control. Your trips to the bathroom often go down to 0. Um, Little things like if you were to drop a set of keys off a shelf and it starts to fall to the ground, after you've gotten a successful sleep apnea treatment, your reflexes will change and you'll catch that keys where before they would have fallen all the way to the ground. There's all kinds of things like that. And how could that be a surprise when you think sleep apnea is your brain? So if you're not treating it, you're getting brain damage. So brain damage is something nobody wants, and yet all these symptoms are going to happen, part of it through brain damage, part of it through effect on your kidneys, your heart, whatever it happens to be. So when this happens, you have to be in a clinical environment where you've seen that person who's had that great response. And when they've had that great response, you've got to go back and say, well, why isn't this person getting a great response? I remember the guy who had the great response. He felt great that first week. Oh, well, you know what? He's different than this guy who came back for his 2-month follow up and says, I'm still not getting any benefit. The person should be able to think on their feet and say, we must be missing something. So it's very disappointing and frustrating. And, people in healthcare in the United States in particular think that their doctors know what's best for them. And so they don't ask questions. They say, well, the doctor told me to just keep trying harder, just keep doing this. But it's a disgrace, actually. It's absolutely a disgrace because a doctor is supposed to treat people to help them overcome suffering. That's why we're doctors. And if you see somebody suffering, you have an obligation to ask yourself, well, what am I missing? And that's what we did in 2005. And we figured out what we were missing was CPAP just doesn't work for a lot of people. And we wanted to do something that does work for them.
Imagine you're standing on stage. Every single sleep healthcare provider is standing there listening, and you have just, let's say, 2 minutes. What would you want them to know? What do you think are the most important points, easiest to get across and raise?
I just start out by saying, you don't want to hear what I have to say. You're not practicing in a scientific method. Dr. Guilleminault's research has been out there now for over 30 years. There's lots of research showing that flow limitation must be treated. Our own Academy of American Sleep Medicine says back in 2008, I believe, you have to treat the flow limitation. And CPAP can't treat flow limitation. Period. End of sentence. Stop imagining that it can and do your homework and recognize there are better devices out there to treat the third breathing event. And when you do that, you're going to be astonished by how much better your patients do. And they're going to thank you so much. So please go down that pathway and stop thinking about what the insurance companies have to say or the DME companies have to say and learn how to fight for your patients. And read my book, Life Saving Sleep, because in there we describe the process of how in a sleep lab you can actually use the titration experience to demonstrate that these patients are failing CPAP and need bilevel because they're either getting expiratory pressure intolerance or you can't really resolve the upper airway resistance events. I think that was less than 2 minutes, but you know, I mean, I wouldn't know what else to say. I wouldn't know what else to say. I mean, many of these people are my friends and colleagues. I respect them because many of them, do a lot of good work in other realms. But in this particular area, there's a huge blind spot. It's the echo chamber has taken over, and they're mightily influenced by insurance companies, government regulators, and they're not thinking outside the box, and they are harming their patients and letting their patients suffer a great deal that does not have to be.
As you know, there's an infinite number of misdiagnosed, marginalized, gaslit patients out there. They're going to watch, some of them are going to watch this video and they're going to say, this guy knows what he's talking about. I'd really like to talk to him. Do you have any services? Do you have a sleep center? Do you have a consultation service? Can they reach
Sure.
out to you somehow?
Well, I would, in a self-serving fashion, say you might want to start with the book Life Saving Sleep because that knowledge is going to give you so much confidence about what you're really diving into. Not to mention, it's going to give you so much help on things you can already start doing to sleep better. I do run a sleep health coaching service at barrycracomd.com, and that is something where I don't provide treatment, but I do provide an enhanced education so the individual now puts all this together for themselves and realizes how they can work with their sleep doctors to be able to get the services and the care they should get. I have a free Substack newsletter that's been around for a couple of years. It may go to a subscription service, Substack, in the next couple of months because I have another book coming out called Fast Asleep. And I'm thinking about doing a podcast where I'm going to actually work with all of the content in that book where you can read the book, but I'm also going to be diving deep into it and going through all the chapters in greater detail. It's a book on advanced sleep hygiene because I've been a little disappointed in the way sleep hygiene is put out there, and it really has combined elements of my emotion focused therapy with cognitive behavioral therapy with sleep hygiene and put it all into one brief booklet. And then for professionals, I often can still do workshops and trainings for people who want to learn about these models of care.
Amazing. It sounds hyperbolic, but I mean, you're going to help so many patients just by the content of this video. I mean, I can already tell because I've been in this space for a while and I've been around the forums and the patients. There's so much value here. So I just want to say thank you. And I'll put links and stuff in the description box for everyone to go check out your work and your services. And like I said, I already read the book. I'm going to read it again. There's less than 10 books I've ever read twice. So,
Thank you.
I hope that
Thank
says
you.
something. So thanks for
Appreciate
coming
it
on.
very much. Thank you.
If you ever want to do it again too, we can. But let's see how this goes. Let's see what the response is like. And Yeah, I
Yeah.
have your contact information. But thank you so much for coming on. I've read a lot of your literature in the past, and yeah, you've made a huge impact on this field, and people know who you are. There's even, I don't know if you know this, but there's a Reddit, there's a subreddit called Upper Airway Resistance Syndrome, and there's a picture of Dr. Christian Guilleminault and you. Did you know that?
Seriously.
Seriously.
Can you send me the link? I haven't seen it.
Yeah, I'll send you the link. It's one of the smaller ones. It's like where the more technical, fringe, motivated
Right.
resource people are. It's not
Right.
like the huge mainstream one, but yeah,
No, I'd like to see it.
I'll send it to you.
All right.